Observations with Dr. Joe Sam Robinson is presented by the Georgia Neurosurgical Institute. For more than 50 years, the Georgia Neurosurgical Institute has provided comprehensive, state-of-the-art neurosurgical services to the central Georgia community, including treatments of neurological, spinal, and cervical disorders, injuries and diseases, including back pain and neck pain. For more information, call 478-743-7092 or visit ganeurosurge.org.
Good evening. My name is Joe Sam Robinson, and we're pleased tonight to have Dr. Dennis Ashley, who is a professor at Mercer University in surgery and also the chairman of the Georgia Trauma Commission. And tonight it's our intention to discuss trauma. Welcome, Dennis. Thank you for being here.
Thank you, Dr. Robinson, for inviting me.
Well, Dennis, let me start out by asking a few questions about your journey through life as to how you came here. Did you grow up in Kentucky? Where was your...
I was born and raised in Kentucky. I went to Transylvania University for my undergraduate training and then University of Kentucky for medical school.
Now, Dennis, can you beat the drum for Transylvania University? Is there some story about it? It's a rather interesting name and a very old school, I think. Is that right?
Well, it's not a school you hear of very often in this part of the country, but it's actually a very old school. It's only been closed 3 times in its history, and 2 of those were for Indian attacks.
Oh, is that right?
That takes you back a little bit in history.
Really?
That's right. Small liberal arts school.
Well, and did you always want to be a physician? Did you have this? Is that a lifelong calling?
I did. I actually decided to. I wanted to become a surgeon when I was in the 7th grade when I was playing football, actually. I told my football coach one day in the locker room, I think I want to be a surgeon.
Yes.
And from that point on, I didn't change course.
So it was just kind of a straight path for you, and you took some hard courses in college?
It was.
You tangled with organic chemistry?
A little organic chemistry with Dr. Musnik, as they used to call him.
Well, good. And then you went to a medical school, and how did that go for you? Did you enjoy that? Was that a challenging time in your life?
It was very challenging, as you know, doing it yourself. Medical school is fairly challenging, but it was fun, and that led me, to my ultimate career in surgery.
So you had always thought about being a surgeon,
right.
Is that right?
Right.
Yeah. And then I think you came to Macon, Georgia. What happened there? What's the story on that turn of events?
Well, as you know, after medical school, you do your residency, and I went to the Medical Center of Central Georgia for my residency in general surgery.
Yes.
And then after that, developed a love for trauma and
Yes.
critical care and wanted to do some extra training, and went to Grady.
Yes.
Which I believe you spent some time at Grady.
In
if
my
I
younger
remember
days,
correctly.
I passed through there. That's right. Yes.
And spent a year there in trauma, and then ultimately did a year of critical care at Pittsburgh, and been in Macon really since 1988. So now Macon is pretty much my home.
Well, that was your training is rather Olympian, isn't it? I mean, Pittsburgh is right on the cutting edge of intensive care work, and that was. Did you pick a lot up there and bring it back to this part of the world?
Very good year. They were actually the first program in the country to declare critical care as a full specialty and have their own chair. So they developed their own department.
Yes.
And that's one reason I went there. It was the first department in the country.
Now, Dennis, you've been exposed to this good training in different places. You're back here in Middle Georgia. You're trying to do things, and you're really specializing on patients that have had traumatic injuries. Is that right? I mean, people that.
That's right. That's correct.
And have you seen progress in your days in this specialty?
Well, as I said, I've been here since 1988, and we've come a long way, both regionally as well as at the medical center, with the development of our trauma team. When I first got here, we really didn't even have a trauma team per se. The trauma patients were covered by multiple different services. There was no organized trauma service. So as I got out of my fellowship from Grady, Martin Dalton, who was the chair of surgery at that point, wanted to organize a trauma service, and I believe working with you at that point, put together the first formal trauma service and asked me to be the director. So since about 1993, 94, we've had an organized trauma service at the medical center.
Oh, well, all right, Dennis, let me just ask you some questions about, and maybe this is for the audience, just to understand how medical science has progressed in treating trauma. But let me give you a hypothetical situation. Let's say there's a young girl that's, I'll say she's 18 years old, she's in Warner Robins, she's walking down the street. A drunken driver swerves, hits her, knocks her in the air 20 feet. She's found on the sidewalk, bleeding, senseless. What's going to happen next in this situation, in this area? What are we going to do about that to help this young lady?
Well, the main thing is getting paramedics to her very quickly so that they can give her oxygen, monitor her blood pressure, stabilize her cervical spine, and then really get her from that dangerous environment into an environment where she can receive life-saving care. And the best place for that is at a trauma center. So with the case that you presented to me,
yes,
she could have severe internal injuries, probably a pelvic
yes,
fracture
yes,
being struck by a car, and probably a severe brain injury.
Well, let's just go through this. So we have these situations, and in many circumstances, this young lady would not make it. Is that correct? Unless the person gets really cutting-edge care with this kind of injury, there is a very high death rate and permanent morbidity rate, is there not? I mean, is that correct?
That's correct.
And in the United States, many people die with trauma every year. And is that a fairly substantial cause of death?
It is. It's the leading cause of death in folks between the age of 1 and 44. The leading cause of
yes,
death.
But if we can get this lady to an appropriate place, then we can do something about it. Is that correct? Well, let's discuss what you would actually do in this case. So the patient is going to come to the emergency room, and then what would be the protocol to try and redeem this person? What would you do? How would you intervene? What would be the test you would order? What would you do?
Well, the thing we always think of first is the airway. We want to make sure the patient has a good airway so
yes,
that they can get oxygen. Second thing is to make sure they're breathing, make
yes,
sure their lungs are expanded, they don't have a collapsed lung.
Yes.
And then the third thing we look at very quickly is their circulation. Are
yes,
they bleeding internally? And as you know, at the medical center, we have ultrasound in the emergency room, so without removing the patient from that environment in the emergency room, in our trauma room, we can very quickly look internally and see if they're bleeding. The patient that you gave me sounds like they probably have a head injury and possibly a pelvic fracture. So we have x-ray equipment mounted right there in the emergency room that we can x-ray the pelvis without moving the patient and very quickly know, do we need to put a binder on the pelvis and stop the bleeding or do other tests?
Well, all right, Dennis, let's just say she has a substantial pelvic injury. What are you going to do? I mean, what's going to happen next? We'll say we have that particular organ system that's been affected.
Well, the first thing is the pelvis, you can lose your entire blood volume within the pelvis. So we want to tamponade or contain that blood loss if we can.
Yes.
So we put a binder, we have binders right in the emergency room.
Yes.
We put a binder around the pelvis, stabilize it, tamponade it, and then if it's bleeding enough, we can take that patient to arteriogram, where our radiologist can put a catheter in the artery, put some contrast through that artery, see where the arteries in the pelvis are bleeding, and then put little coils or pieces of material in there to stop up that artery.
So that's a rather new thing, isn't it? I mean, going back to the Stone Age, let's say 20 years ago, that was not freely available, this kind of technology.
It's become much more available now, that's correct.
So one of the things going on is medical science is making substantial progress to help people when they have these traumatic injuries. Is that fair enough to say?
Right.
Yes. So all right, you've done that. Now, maybe you can opine on the word golden hour, Dennis. I mean, I think that's one that we occasionally hear on the lay press, and we have the patient in. What exactly does that mean, the golden hour, for this young lady?
Well, let me put it in perspective as far as bleeding. If the average person has about 5 liters of blood. You think about that, the average citizen, you go to your refrigerator, you've got a bottle of beverage in there, a 2-liter bottle. You've got about 2 of those bottles, maybe another half of another bottle in there. That's your blood volume.
Yes.
So as you get hit by a car or fall off the roof or fall off the motorcycle and have this trauma and you're bleeding internally, just think about that beverage, if you will, draining out of the bottle. It doesn't take long for that just 5 liters, 2.5 bottles to run out. So you can imagine now why we call it the golden hour. If we can get you quickly within that hour, not from the time that the call's made, but from the time that the accident happens, it gives us a better chance to stop that bleeding and preserve your blood volume.
So this is one of the arguments for putting an appropriate trauma system in place in Georgia and indeed nationwide. If we can't get that young lady where she needs to go very quickly and she exsanguinates, we're not going to be able to preserve her life. Is that fair to say?
That's true.
So,
as a matter of fact, we do a better job of getting soldiers off the battlefield in Iraq and Afghanistan and under enemy fire to a trauma center or a MASH unit, whatever you want to call it, than we do in Georgia. Their system is much more organized
Yes.
than ours.
well, let's suppose we have this young lady with these multiple injuries present. We have a pelvic fracture. We're going to deal with that. And what's going to happen, shall we say, with some internal injuries? We've got a substantial liver laceration. Maybe we've got some free air in the peritoneum. What's going to happen now? I mean, what are you guys going to try and do at this point?
Well, at this point, you've given me the diagnosis. We've got free air, so something has ruptured. Some intestine or stomach, something has ruptured. So we need to patch that hole and stop the spillage of the contents into the abdominal cavity. You also mentioned a liver fracture or a liver contusion, so
Well, I'm making it a
that
little
may be
tough for you,
bleeding.
Dennis, yes.
Okay, so we're going to have to stop that bleeding. So what that patient needs then is an operating room with a surgical team to open the abdomen and go in and fix whatever the damage has been done.
And so if, just in Georgia, if this kind of facility is not easily accessible, the patients are going to be at a substantial risk, are they not, for survival. But assuming that this is the case now, pretty much in Middle Georgia, is it not? On your service, you have access to the technology to help the person. Is that fair to say?
That's right. That's the nice thing about our trauma center, in that we're there 24 hours a day, 7 days a week. So if you come in and need a surgeon, we're there. As a matter of fact, when the trauma beeper goes off, our code is 444 in our beeper.
Yes.
We assemble an 11-member team that's there waiting for you when you come in. And then the next step is to go from the emergency room to the operating room. This is what gets a lot of emergency rooms not in trouble, but doesn't allow them to provide that rapid access, is they don't have a 10 or 11 member team. They just don't have the resources to provide that. And then if they stabilize the patient in the emergency room, they don't have that rapid access to the OR. Many times surgical teams are at home. They're not even in the operating room, and it may take them 45 minutes to get to the hospital and get set up. And remember, we said we had the golden hours, so if it takes 45 minutes to assemble our team, well, that's 3/4
So
of the hour.
your team is ready to go 24 hours a day. Is that fair to say?
That's right.
Yes. And so you're going to be able to really aggressively do something to help this young lady. All right, so you're going to take her to surgery, and then suppose there are multiple organs involved here. I'll toss in a brain injury, something in my bailiwick a bit. Well, so we're blowing a pupil. We've got, and they were having belly problems. We've got a pelvic fracture. This is the way these complicated patients present, is it not? After a substantial injury, it can be pretty much a total body smash-up. Who's captain of the ship? How are we playing this? How are we going to redeem the situation in this, with many organ systems involved? How do we do that?
Well, you've given me, I think intentionally, a very complex patient here, a very complex trauma patient.
Yes.
So while we're operating on the abdomen and stopping the bleeding from the liver or repairing the intestine, remember you've already given me the pelvic fracture.
Right.
So remember, there's a binder on the pelvis now, tamponading that bleeding.
Yes.
While we work on the abdomen, and now you've thrown in a brain injury. So now we've got the orthopedic surgeon involved on the pelvis. We've got the trauma surgeon involved on the abdomen. Now I've got to involve yet another subspecialist, the neurosurgeon, for the brain.
Yes.
So you see now I've got 3 specialists on one patient within a matter of minutes to save this patient's life, and it's very doable.
Yes, and that's what happens every day. That happens every day, does it not?
Right.
So multiple specialists are going to try and do something to help this person 24 hours a day. That's a rather good situation, is it not? If the patient can get to that facility.
Right, that's the key. The patient has a fighting chance if they can get into the system rapidly, and we still have something to work with. If the patient shows up and really without signs of life, there's occasional save that we can make.
Yes.
But most of the times, if they show up with no signs of life, then the battle's over.
Right. Now, Dennis, what about access to blood? I mean, the Red Cross does yeoman work. We've got this young 18-year-old person in this smash up, and have you seen cases where there's been substantial blood loss? I'm throwing you a softball here.
Right.
Is that
Yeah.
right?
Oh, there are many cases with
And
substantial
we really
blood
need
loss.
the blood, is that correct? I mean,
We
and so
do.
the people that are blood donors are really, really helping people. Anybody that does that, I mean, it's really quite commendable.
Right. These are the unsung heroes to the trauma team, because on days on these blood drives, you know, nobody really notices them.
Yes.
But we know they're there.
Yes.
And certainly when we're in the trauma bay,
Yes.
we need that blood and we need it quickly. As a matter of fact, we actually have someone from the blood bank show up in the trauma bay with blood in the cooler, ready to go in case we need it. That's how rapid access we have
So
to blood.
that people just have to have that blood, and the people that donate that blood in their own blood in this area, really, they're quite heroic.
They really are.
And both of us say that and say thank you. Is that correct?
We do. The trauma team is
We
very
say
thankful.
thank you, and we could not save people without that donation.
That's
Is that
correct.
fair to say?
Yes, sir.
Well, all right, Dennis, we have a lot of blood loss here. Tell me what happens if you're really bleeding. What are you going to do? I'm going to imagine you've got a liver problem and you're having terrible bleeding problems. And what's going to happen if you really need a lot of blood? What does the blood bank do to get you what you need?
Well, we have actually a new protocol. There's a few of these around the country that we're going to start at the medical center, which is called our massive transfusion protocol. And basically that's all hands on deck. It's special units of blood where we get blood
Yes.
along with the clotting factors. It's
Yes.
not just good enough to have
Yes.
blood, you have to have the clotting factors in there with it, called fresh frozen plasma,
Yes.
along with platelets. And
Yes.
so now we have the capability of getting all that very quickly as opposed to having to wait for it. So this is the new wave that's sweeping the country in blood management, is massive transfusion protocols. And I'm happy to say we're just starting to institute that at the medical center. We've written our protocol, and that's going to get off the ground within the next month.
Well, you know, I think what our viewers need to realize is that medicine is not standing still. There are many people that are trying to do the very best they can and improve the quality day by day. Maybe you could talk a little bit about some of the issues about clotting after blood clotting. Hemostasis is a huge issue, isn't it? After massive blood loss, and that really can be a daunting problem.
It really is, and
Can you talk a
especially
little
with what
bit?
you
Yeah.
deal with
Yes.
the brain.
Yes.
Because if there's bleeding in the brain, catastrophic, there's no room for it to expand. So the pressure is on us as trauma surgeons to try and keep those clotting factors
Yes.
at the right level for your brain injured patients.
Yes.
And we've learned a lot from actually the Iraq War, and we're getting information from our military over there. And the interesting thing that they found was if you give a lot of blood, you get, without clotting factors,
Yes.
for these soldiers that are terribly injured,
Yes.
limbs, arms, legs, blown off with
Yes.
these terrible explosions, tremendous amount of blood loss. And what the military realized is that they needed to give the blood, we call it packed red cells, it's just the red cell component of the blood. They would give a unit of blood, then they would give a unit of plasma, and then they would give a unit of platelets.
Yes.
And actually now there's the new talk, this is coming back to the civilian trauma centers, giving 1-to-1. In other
Yes.
words, keep the ratio 1-to-1-to-1 or either 1-to-2. And by doing that, you prevent a lot of the coagulopathy or the bleeding problems. So that's one way that, as bad as war is, and every conflict from World War II to Korea to Vietnam, we've always learned something that has helped the civilian trauma centers from the issues on the battlefield. And that's one of the newest things we've learned is about blood therapy, which
Yes.
you were asking me
Yes.
about.
Yes. Well, Dennis, now that's only half the story. Is then if we can get that person through the acute injury stage. Let's see, we've got her patched up. It's still quite a stormy course, isn't it? What happens next? We'll imagine this patient has been stabilized. The abdominal issues have been dealt with. We've got this pelvic fracture that's sitting there, and I'm going to say that she has some increased intracranial pressure, and we have an intracranial pressure monitor in her. And what's going to happen next?
Well, as exciting as it sounds, and the things that we've talked about in the first hour or couple
Yes,
of
yes.
hours, that's really just the start of the battle, as you
Yes.
said. That's the easy part.
Yes.
Stopping the bleeding, getting the patient to the ICU, out of the operating room. Then we have to really start dealing with that head injury,
Yes.
the swelling in the brain. And as
Yes.
you know, we could ask you to pontificate a little bit about that, about what we do with draining hematomas. That would be a very important aspect of our care. but also in the ICU when you put in the monitor so we can monitor the brain pressure. We worry about swelling because, as you know, we've got the brain inside this box that doesn't expand, the skull. And it's a catastrophic event if it expands and we can't control the swelling. So that's when we rely on our neurosurgeons to help us get that down. I might kick that back to you and say, you know, what are some of the techniques we could do here to help us manage the ICP or intracranial pressure in the ICU?
Well, I won't be too long-winded about it since you've thrown me a so-called softball. But in traumatic brain injuries, really what we worry about is the cerebral spinal fluid circulation and also just primary brain injury. So what happens after a cell has been injured? There's something called the sodium pump that kind of keeps the cell the right size, and if the sodium pump is injured, there's primary brain swelling that occurs. And what we try and do is prevent that swelling from becoming so extraordinary that it puts pressure on the brainstem. So we have a number of tricks in our bag to prevent that. Basically, it involves trying to dehydrate the brain so there's enough room. We sometimes put people in barbiturate coma. We often monitor intracranial pressure. There's a whole host of complications and difficulties that occur. And I think maybe I'll just ask, we can talk a little bit about this. In some ways, trauma is the amount of torque or force that a body is subjected to is a little bit like radiation. So if a body gets too much blunt force, I guess, to injure it, the body has a difficult time in recovering. And so with the brain, if there's so much blunt force, sometimes we see recovery is not possible. It may take a while for that to occur or for us to understand that. And another issue there is many times it's a complicated story about getting people back to the custody of their families, and many times there's such substantial brain injury and spinal cord damage that we make decisions about how aggressive to be, which is a complicated kind of thing. And I know you face that similar dilemma in many times, do you not? If we're expending huge amounts of resources trying to save lives, is there a time that you would say to the family that's we're not going to win on this, it's time to stop? I mean, do you have that? Do you have that interchange?
Unfortunately, that we have patients that we can't save, and we do have to have those interchanges. And that's a complicated situation because there's no right or wrong answer.
Yes.
Every family's different.
Yes.
And basically what it comes down to in the end, you have to find out, since you don't know that patient usually. I usually meet these people for the first time as my patients when these terrible traumas.
Yes.
And what I always try to do is find out what the patient would have wanted if they could talk to me.
Yes.
And by piecing that scenario together from loved ones, and a lot of times they will tell me, you know, my husband or my wife or my child wouldn't have wanted to live in a comatose state, or they would want this therapy or not. And we try to make a treatment plan that's individualized for them. And usually by talking to the families, we can piece that together. And the second thing I try to remember is dignity for that patient. What would they want, or again, what would they tell me if they couldn't go on? How would they want to go? And working that through those issues with the families are very complex, but it's very doable. And unfortunately, we have to do that, you know, several times.
Well, that's a very difficult thing, and I mean, I think both of us can say one of the things that can happen, family units can be destroyed by this, can they not? A loved one that's been injured and grievously injured, it's really stressful on the family. I think both of us are aware of how important family dynamics are in the healing process to get through this. Now, all right, I'm going to say that we've been successful with this 18-year-old girl, and she's let's say she's getting better. And let me toss this issue in. Suppose there's been a disfiguring facial injury. I mean, what are we going to do about that, Dennis? In the middle of all this, we're saving the patient. What are we going to do about the disfigurement that might occur after traumatic injury?
Well, now you've brought in yet another scenario, but a very common scenario. That because when people hit the windshield or get thrown out of a vehicle, hopefully they're wearing their seat belts, which really stops that in most instances. But we've got a terrible facial trauma. It may be broken bones underneath the face. There may be terrible lacerations or cuts. And fortunately, we have plastic surgeons as a part of our team that can put that back together.
Yes.
Either bone-wise, with sometimes plates and screws in the face under the skin where you can't see them, but to reconstruct the bone. And then with the soft tissue with the face to close all those terrible, terrible wounds. So that is a part of our team, the plastic surgeon, and fortunately they do a great job in getting these patients, really back together where they can function in society.
All right, great. So I'm just taking you through this case. So the young girl is getting better. She's talking to her family, and then we're getting better on a daily basis. What's going to happen with rehabilitation, and what's going to happen next in this story?
Well, this, as I tell families as they come through, it's almost like a journey in the sense that they're going to start in the ER or maybe the OR. They're going to progress in a critical case like this girl to the ICU. Maybe they're a day or two or a week, maybe even 3 or 4 weeks. Everyone's different. And then they'll progress, they'll graduate, if you will. It'll be graduation day from the ICU.
Yes, that's always a big day.
That's always a big day for the families. And then they get to go to the floor, a regular room.
That's a wonderful day, isn't it?
That's a big day.
Family. Yes,
especially because then you know they're going to live.
Yes,
They've made it through the crisis,
yes.
and now you can see a light at the end of the tunnel, and they're going to move into the floor. And then the next step is rehabilitation.
Yes.
Intense physical therapy. Hard work on the,
Yes.
I tell the patients then they're usually out of their coma, they're alert, this girl would be awake. We say, well, now really the work starts.
Yes.
We're going to work you hard, the therapists are going to work you hard. And that takes a whole nother team of professionals that do that on a daily basis.
So the courage of this young girl and also her family is very important. A supportive family in the recovery issue is really of tremendous consequence, isn't it?
It is. Because, again, I tell the families, too, this is a marathon. People come in and they're shocked. As you mentioned something a while ago that jogged my memory about how trauma occurs. It's very rapid.
Yes.
They don't have time to think about it or plan for it or say, next week I've got to go see the doctor about this terrible condition.
Yes.
Someone is on their way to work of a morning or they're on their way home from something at night, and it happens. And so families are in shock when they get there. It really destroys the family dynamic and puts it under tremendous stress. And then they really want answers. They want it to be over very quickly. How are you going to fix my loved one?
Yes.
And we have to just prepare them sometimes and say, this is a marathon, not a sprint. Your loved one may be weeks or even months getting through this.
Yes.
And once they settle into that, then some of their stress, is dissipated, and they can focus on the task at hand.
So actually, counseling is an important part of this. Just understanding the nuances of a different life situation and coming to grips with that. That's an important part of the healing process, is it not?
Right, for the patient as well as the family.
And so I think everyone out there, there's no assurity in life, is there? Anyone can be struck down at any point as you just walk down the street. Anything can happen. And having your service available in this area, I think, is an extraordinarily good thing. Now, Dennis, do you have any remarks as we sort of close our session tonight on where you think the future of trauma care is going? Any comments about that?
Well, I think we've tackled the problem of the trauma center.
Yes.
If you're in a trauma center, we've worked out protocols. We're pretty efficient.
Yes.
We're rapid. We do a very good job. What we need to do now is, if you will, move that circle of excellence outside the trauma center to those areas in rural Georgia that don't have that.
Yes.
Because the data shows, as you move that circle out from a trauma center, the farther you are from a trauma center and have a trauma, your death rate goes up. So everybody doesn't live right next door to a trauma center. There's only 16 in the entire state. And if you do, like the people in Macon may say, well, I live next door, I'm blessed, I'm right by a trauma center, I have no worries. Well, what about when you go to Disney World?
Yes.
What about when you drive to Panama City on vacation? Or what about North Georgia to the mountains for a weekend?
Yes.
You're very quickly away from the luxury and protection of your trauma center. So my goal would be, as I get older, would be to make sure that everyone has that same access throughout the state, regardless of where they're hurt, not just hot spots.
Well, great, Dennis. I'm happy you've said this, and we're going to next week discuss how we can change the dynamics of the trauma system in Georgia. So thank you so much. It's been enjoyable chatting with you, and it's been an informative time. So we'll see everyone next week, and Thanks a lot, Dennis. Thank you.
Thank you.
Observations with Dr. Joe Sam Robinson is presented by the Georgia Neurosurgical Institute. For more than 50 years, the Georgia Neurosurgical Institute has provided comprehensive, state-of-the-art neurosurgical services to the Central Georgia community, including treatments of neurological, spinal, and cervical disorders, injuries and diseases, including back pain and neck pain. For more information, call 478-743-7092 or visit ganeurosurge.org.